Thank you so much. Great to come back to this part of the country and to be reunited with Liren, because it's been a while since we saw each other. So fun to be here with you today. Now, right away, I have failed the first test, which is how to advance the slides. But I've got my timer going well. Down button, okay, the other one. All righty. So I have one disclosure. I'm on the board of directors of Zymeworks, a company that's making ADCs, but is not yet in the clinical space. And I also want to point out that, like one of our speakers this morning, I reached out to our colleagues. And so I had the opportunity to really be assisted by the presentations of Erica Mayer and Antonia Wolf from their presentations at ASCO in the breast cancer space. So please know that they've helped us greatly. So in the early breast cancer space, and I'm going to look at early and at advanced, there were several abstracts that I think caught people's attention. First of all, triple negative breast cancer, really one of our nemesis right now, a couple presentations in that space. And the second is in the ER positive HER2 negative space, thinking about some of the predictive markers. So 4 abstracts that came out of ASCO in that particular setting. Now, can I ask you, I have my timer going at like milliseconds. How do I get rid of that? What little button do I press? All right, very good. No, it's on. It's at 1 hour, 24 minutes, and 68. I know. I'm wondering.
This is all you get, either this or off.
Okay, fine. Not to worry. So the first one is the A-BRAVE study that I want to tell you about. It's an adjuvant checkpoint inhibitor, and then we want to talk about a couple of the other trials. So first, let's think about how do we treat early triple-negative breast cancer right now? Well, the KEYNOTE 522 trial really changed what we do in a neoadjuvant setting. This is a study you'll recall, the design on the right, that added PD-1 inhibitor pembro to preoperative chemotherapy for early triple-negative breast cancer. And actually, just a couple weeks ago, the most recent update of this trial was published in the New England Journal of Medicine. You can see the curves down there in the bottom right. And you can see that in aggregate, this trial right now has shown significant improvements in PCR, which we knew a long time ago. But also the 5-year event-free survival is about 10% better with the use of the pembro. And the overall survival at the present time at 5 years is about 5% better. So I think that this has obviously really changed considerably how we think about triple-negative breast cancers, and it has led to a lot more use of neoadjuvant chemoimmunotherapy. Now, of course, that leads to some questions for us. What about adjuvant IO? Supposedly you gave only chemo and now you're in the adjuvant setting. Is there a role for it? And the second is, do you think we could get away from chemotherapy in this setting? Could we use combinations of biologics that might get us out of this difficult situation? Well, into that comes A-BRAVE. And this was an adjuvant study, high-risk triple-negative breast cancer patients. They'd had chemotherapy, but no prior IO exposure. They have finished their chemotherapy and their surgery, and there were 2 groups. The one group got it strictly adjuvant. You can see that was about 20% of the patients. And the other group were women who were selected because they were in the post-neoadjuvant phase and they still had residual disease, so they did not get that path-CR. Simple design, avelumab is the agent of choice. Several endpoints, as you can see there. And this is a kind of a confusing trial because you can see that a couple of the endpoints, including the disease-free survival, a key one, didn't show any statistical advantage in either group, the group as a whole or those post-neoadjuvant patients. But there was an improvement in overall survival, and there was also an improvement in distant disease-free survival. So where we are with this trial, in my view, is no statistical differences in the 3-year disease-free survival, some improvements in the overall and distant disease-free survival, toxicity, just what you and I would expect with a checkpoint inhibitor. And remember that this was done before the KEYNOTE work was available, and so we don't really, I don't think, know exactly how to incorporate that into our practice at this point. So the role of adjuvant IO is still a little bit up for grabs. It's not that it hasn't been studied. Remember the IMpassion30 trial looked at adjuvant chemotherapy with or without atezolizumab. And you can see the design there, a huge trial, 2,300 patients, flat out negative, right? No improvement in invasive disease-free survival, overlapping curves that you can see there on the right. So this is also not a very impressive result. And I think in this country right now, from an adjuvant consideration, we're waiting for the results of one of our intergroup trials, this SWOG NRG trial, which focused particularly on people who had residual disease after neoadjuvant chemotherapy and used Pembro, which you would argue is the agent that we're the most commonly using in the setting of breast cancer. Larger trial than ABRAVE, and so we'll have to see what happens with that, whether that helps us to think about a role in the adjuvant setting for a checkpoint inhibitor. Just now, I think most of us would steer away from it, and we try, if we're going to think about it, to use it in the neoadjuvant setting for a lot of the rationales that we heard in other disease areas earlier today. Now, the second trial I want to highlight comes out of that I-SPY trial. And remember, John talked about that briefly this morning and how they're trying to take I-SPY concepts and bring it into GI cancers. Well, this has been a trial that I think has really given us a lot. And this particular iteration of I-SPY looked at using Dato, I'm going to call it Dato, too hard to say, and durvalumab, or Durva, in the neoadjuvant setting. And so you know that they've refined I-SPY a little bit now, so they're looking at sequential types of therapies, and they're evaluating along the way to try to figure out what gives positive signals and where you need to go on. So remember, the patients that go on this trial are deemed at high risk for their early breast cancer because of a mammoprint. And in this trial, they went on to Data plus Durva, so a non-chemotherapy combination, right? That's their first treatment. And then a subset of those women, out of those 106, 35 of them were felt at their first analysis to not show any obvious disease, so they went to the OR. No further, no chemotherapy to get to that point. Those that didn't look like they'd responded, they went on to Taxol Carbo, and those that didn't do well with that went on to an anthracycline with a PD-1 inhibitor. So you can see the sequential opportunity to try to think about what is the least amount that you can get away with. So of course this is a signal finding trial, right? And what we learned from this particular trial, small preoperative trial, is about a third of the patients were able to go to surgery without having any exposure to neoadjuvant chemotherapy. And in their algorithm, that actually meets the threshold to allow this to be tested in more advanced, in larger trials. They also found in some discovery stuff that immuno-rich, if you will, the immune-positive subgroup histologically were the groups that seemed to profit the most. And this also suggests, and this is very indirect comparison now, right? If you look at the results of Dato monotherapy or sacituzumab monotherapy in this particular setting, you can see that the PCR in triple-negative breast cancer is a little higher with the combination of those two types of agents than monotherapies. So stay tuned, interesting signal. Maybe we'll be able to get to ourselves to a point where we can use all biologics in some of our triple-negative breast cancer patients, at least in the neoadjuvant setting. A lot of questions, though. First, this trial might help us to think about whether you could at least get rid of the anthracyclines, right, because that was at the very end. And then this question of whether you could replace all pre-op chemotherapy is actually being tested in the Tropion Breast 4 trial that you can see here, which is using Dato and Durva, again, in the setting of neoadjuvant triple-negative breast cancer. So let's watch this space and see if we can make any headway. Now, the second set of two abstracts in early breast cancer that are of interest more have to do with markers. And I think there are also examples of trials that kind of keep on giving even after the primary result has been reported. So the first is something that came out of the Monarch-E trial. Remember that? That was an adjuvant abemaciclib trial, right? That was the trial that led to its FDA approval. And so in this particular trial, what they did was actually go back retrospectively and look at ctDNA and samples that had been stored. And so you can see the ctDNA cohort, which was felt, I think, to be pretty representative, was about 900 patients. And they looked at detection. So you can see that most people were baseline negative, 92%. But there were a handful who were, many of those people remained persistently negative, but there were a handful who, with time, became positive by their assay. A small number of people were baseline positive on that first assay. They found ctDNA. And some of those folks continued to be positive, whereas others became negative over time. And so you can see about 17% were positive at any time during the surveillance. The vast majority were negative the whole time. So this question is then, so what? What does this mean from a clinical perspective? And what they were able to find was two things. First of all, like in a lot of situations, your baseline CTA is associated with poor outcomes. If you have it, those folks tend not to do as well. And the second is the dynamics may have some, on treatment, may have some implications for outcome as well. And so in this graph, you can see 4 different groups, right? The blue people at the top, they're the many, many women who were persistently negative for ctDNA, right? The next group down, those were folks who became negative. They might have started positive, but they converted. The red folks became positive. They started negative, they converted. And the folks at the bottom were the ones that were persistently positive across all the samples. So this certainly provides information to suggest that this has prognostic value. It also suggests that maybe, we could be using clearance of ctDNA in the future to try to document potential benefits for therapy. Now, I have to say, I don't think this is ready for prime time in breast cancer. And I just want to let you know there are a ton of trials that are going on right now in the breast cancer space, looking at interventions, the role of an intervention in the setting of ctDNA positivity. These are the ones that were provided by Dr. Bedard a few months ago. I wouldn't be surprised if there are more. But for me, at least, Nancy Davidson, I am not monitoring this, and I am not using this to make changes in therapy for people with early breast cancer. All right, the other interesting one in the early setting, and this comes out of the SWOG trial, which is the responder trial. You remember this is a trial that looked at women with 1 to 3 positive lymph nodes, receptor positive, using Oncotype and trying to decide the pros and cons of adding on chemotherapy. And you remember the key results of this trial were that chemotherapy benefit differed by your menopausal status. If you were premenopausal on the left, you can see that there seemed to be value to the addition of chemotherapy. If you were postmenopausal on the right, no value to adding chemotherapy to endocrine therapy at all. Now, a lot of effort to try to think about how to tease that apart better, because premenopausal is kind of like a broad category, right? A clinical definition. And so these folks have been trying to think about what are the role of the various parts of therapy in that setting. Is the chemo in these young women actually having its own independent effect, some cytotoxic effect? Or is it really just a menopause inducer in these younger women? And so this particular analysis wanted to look at determining chemotherapy benefit if the women were less than 55 years old and had a low ovarian reserve, so presumably they were well along in that menopausal transition. They looked at a bunch of things that you might think about in that setting, and the one that they really identified was Mullerian hormone, as you see here, anti-Mullerian hormone, AMH. And they suggested that that might actually be of considerable value in trying to tease out who's who in terms of looking at the chemotherapy value in these premenopausal women. And it did so. You can see that a subset of women on the left had low AMH. Chemotherapy didn't help them at all. And the women on the right who had the medium or the high AMH, they were the ones that seemed to have the benefit with the chemotherapy. So I think this helps us to begin to try to subset categories of women a little bit better to try to be more refined in how we try to think about the relative roles of our various types of adjuvant therapy. I'm not measuring it yet. I'll be interested. Is anybody else, is anybody here using this as a matter of routine in your practice right now? Oh, I'm glad to feel I'm still in the majority. Pretty new, but I think this is the kind of thing that we'll be looking at in the future. So here's what I think we learned in early breast cancer. ABRAVE, other trials, we're still looking at whether adjuvant immuno-oncology matters. We're hoping that maybe we'll be able to use combinations of biologics in the future in order to potentially reduce or even remove the use of chemotherapy. And we just talked about a couple of markers that are being intensively studied right now, ctDNA and this AMH. And so I would say stay tuned, let's see what emerges over time and whether these will become a routine part of our practice. Now, in the metastatic setting, I'm reliant here on the contributions of many. There were several different abstracts that are summarized here. You can see in each case the name of the abstract in the middle, what was presented, and then the one-liner on the side about what was the punchline for that particular presentation. You're going to be happy to know I'm not going to discuss all of them, only the ones in the red on each slide. It'll be a very brief discussion of each. So first, let's look at the Kalinsky abstract, the CDK4 inhibitor after CDK4 inhibitor. Okay, so now we're giving adjuvant CDK4 inhibitors, and we're trying to figure out what we should do if somebody has progressive disease thereafter. And so the Monarch trial that we already talked about is trying to look at this. And in this particular setting, presented by Kevin Kalinsky, they looked at people who had had disease progression on a CDK4 and 6 inhibitor and an AI, or who'd had recurrence thereafter, and hadn't any treatment for their new advanced breast cancer. And those folks were randomized to abema plus fulvestrant or placebo plus fulvestrant. And you can see in the curve on the left that the women who got the abema plus the fulvestrant did better. And so at least from the point of view of progression-free survival. So I think this is starting to make us think about whether or not we should continue these agents in some fashion, even at time of first progression. Other work going on with some of the other CDK4 and 6 inhibitors, and so I think we're going to see that we're going to have to come to some kind of consensus about that in the relative near term. The second thing is to think about the long-standing question about, especially in premenopausal women, chemotherapy versus endocrine therapy in the setting of metastatic disease. So here's a very nice phase 2 trial, right? So it's not definitive, but it's an interesting trial that looked at LHRH agonists, so ovarian suppression, plus exemestane, plus palbo in these young women, and confirmed it, or compared it with the use of capecitabine, so a monotherapy. These folks were, of course, well selected because they were receptor positive. They'd only ever had tamoxifen before, and they could have had one line of chemotherapy if the investigator wanted. And on the bottom left, you can see the progression-free survival curve, which suggests, if anything, that the combined hormone therapy group is doing a little better than the capecitabine group. And on the right, you can see that the survival was really no different between the two. And hidden in the table on the top right is the notion that you can do crossover. It turns out that if people respond to one when they progress, you can move over to the other. And so I look at this as something that allows us to have more options for young women who are in this setting, which would be the appropriate thing for them when they think about outcomes and when they think about side effect profile, including the scheduling. Just to keep in mind, though, that young women, it's not always all chemo all the time. And then the other trial that was presented, again, I think it's been presented in a lot of iterations over the last year. And here I've actually just fast forwarded, and I've taken you to the New England Journal of Medicine paper that was published 2 days ago. So this is the most updated presentation of this particular trial, the Anavo trial 120. And this is one where we're looking at another AKT inhibitor, PIK3A inhibitor, inavolisib, sorry about that, in the setting of PIK3A mutated disease. You know, we've already got 2 other agents in this setting, right? And so this particular trial was looking at this new agent in the setting of advanced breast cancer, receptor positive, HER2 negative, had to have those mutations for PIK3A. And this was a high-risk group in the sense that they had to have disease recurrence or progression either on adjuvant endocrine therapy or within 12 months, so relative hormone resistance. And I want you to know that this trial predated the use of adjuvant CDK4 and 6 inhibitors, so like 1% of the patients had exposure to those. Median progression-free survival, bottom left, very, very positive for the addition of the novel agent. So we're now looking at advantage with this triple approach. And side effects, extremely important here. You know, these agents have been sometimes a little bit difficult, especially with their glucose control. And you can see that placebo and the novel agent, not a major impact on several things like neutropenia. And the hyperglycemia, stomatitis, and diarrhea were the high grade, were in a reasonable range. And so as a consequence of this, you probably know that the FDA approved this agent within the last couple of weeks, so this is a new part of our armamentarium. I, at least, am struggling with how to use these 3 agents, which is best, and I think this is going to be sort of like what we faced in the past when we looked at CDK4/6 inhibitors and what we faced before that when we looked at aromatase inhibitors, but it's always nice to have several options to be able to discuss with our patients. Second area, got a lot of attention, was ADCs. You know, they're everywhere, several trials that were reported. I'm only going to focus on one that actually goes back to a theme we heard when we heard about GU cancer, which is an enfortumab, and you know, that's the Nectin ADC that was discussed earlier. And just to let you know that, as is often the case, it's also been evaluated in breast cancer. It was looked at both in the triple negative and the estrogen receptor positive space in metastatic breast cancer. These were individuals who had had some previous chemotherapy, so they were not treatment naive. And you can see that pretty standard administration. And I think you can see that both groups, the HER2 negative, HR positive, as well as the triple negative breast cancer, showed activity, although they didn't actually meet the threshold for activity, which was predetermined by the trial. So I look at this and I'm thinking, I'm not quite sure what to do about this agent going forward, but certainly it's something that has some demonstrated activity in both of these subtypes of metastatic breast cancer. Lastly, we're very much interested in partnering and trying to think about how we can put our agents together in appropriate combinations. And so there are two in the metastatic setting that I'm going to bring to your attention: the Emerald trial and the Patricia trial. Okay, Emerald came out of Japan. The question, this is a non-inferiority trial, a non-inferiority phase 3 trial. And so they were really interested in whether or not one could substitute eribulin for the taxane, which is the chemo backbone that we usually use in the setting of first treatment for HER2-positive metastatic breast cancer. And so you can see the design there, randomized 1-to-1, eribulin plus trastuzumab and pertuzumab versus your taxane of choice, plus trastuzumab and pertuzumab, which is our standard, I think, right now in this particular setting. Usual endpoints that you and I would expect to see in this kind of trial, with progression-free survival being the primary endpoint. And what this showed was that there was no difference. And in fact, they did meet their non-inferiority goal that they had wanted to meet, so that you could use eribulin safely from a point of view in place of a taxane, both from a PFS and an overall survival benefit, as you can see here. What was found, though, is that the eribulin has more neuropathy, and so that may be something that would give you thought as you're potentially thinking about substituting in this drug. And then finally, a complex trial to remind you how hard it is to do these trials. So this is a phase 2 study, and what they were interested in was trying to think about trastuzumab plus optimal endocrine therapy with a CDK4/6 inhibitor now, right? Versus what you might normally choose in first line HER2 positive now PAM50 luminals, right? So we're sub-setting, right? Advanced breast cancer in this Patricia trial. So a lot of selection. You have to be HER2 positive, you have to be hormone receptor positive, you have to be PAM50 luminal A or B by the Prosigna assay. And if you have those things, then you would be randomized to either the palbo, trastuzumab, and endocrine therapy, or whatever is your norm, your choice. And you can see there's a large number of choices that could be in the physician's armamentarium to choose between. A lot of difficulty doing this trial. I'll just tell you they did not reach their accrual goal, so we could only look at it from a kind of signal point of view. But I think what did come out of it is that, it does look like those folks who got the endocrine therapy combination with trastuzumab did very well if you compare them to the folks who got whatever your choice was. And so that says to me that when I'm thinking about anti-HER2 therapy, sometimes I'm focusing only on the HER2 therapy. And I think we shouldn't forget the endocrine part of this because of those different pathways in those individuals with metastatic breast cancer. So with that, what I think we got out of advanced breast cancer sessions at ASCO this year was, first of all, we're going to be thinking really hard about this CDK4/6 inhibitor after previous CDK4/6 inhibitor. The second is we have a new drug that we can bring into the PIK3CA inhibitor category. When I look at that, that's a pretty expensive combination, all those targeted agents. And so I think it'll be interesting to see how we apply it. And I think the second is that we really don't know exactly what to expect when we bring this into the patients who've already had adjuvant CDK4/6 inhibitors. And so we'll have to see what that looks like going forward. A lot of work looking at other drugs, how we bring them into breast cancer, or how we think about use of drugs that we've had for a while, like taxanes and eribulin. And then finally, I think we're going to see a continuing focus on developing these biologically driven combinations, and that's really exciting. But of course, it means that we're going to be subsetting our breast cancers into ever more little micro diseases, which I think will make our treatment decisions even more complicated, but hopefully better for the patient. With that, I thank you very much for the opportunity to be with you today.
All right, we're opening up for any questions.
Excellent talk. My question is about a p-value. I know none of us are really statisticians here, but one statistician once taught me that if you're looking at 20 things, then the p-value of 0.05 is not really a valid cutoff, because that only means there's one chance in 20 that something will be by chance alone, but you're looking at 20 things, like relationship of coffee with pancreatic cancer, which became a New England Journal paper once before it was retracted. So for anti-Mullerian hormone, they looked at 7 things, and one panned out.
So you're talking about the AMH trial?
Yeah,
Or
AMH
study?
trial.
Yeah.
Shouldn't the p-value cutoff have been adjusted it on my calculator, 0.007, 0.05 divided by 7?
I have to confess, I don't know the answer to that question.
Okay.
I was not involved in this particular trial.
Okay.
I think where you're going, though, is I think what I suggested, which is this is really provocative.
Yeah.
But I heard that not a single person in the room is using it yet,
Yeah,
and I think
no.
that's because we all look at this as something that's a wonderful discovery,
Yes.
and we're looking for a little bit more substance before we bring it into our general practice. The other thing for me, and Lyra, I don't know if you know the answer to this if you're still here, I don't even know how hard it is to measure AMH, right? For a lot of these things that gynecologists use them, we don't use them in the oncology space. You know, I don't know whether the way they assay it is going to be
Yeah.
useful to us or not, because we know that sometimes the estrogen assays that we get, right, they may not be low enough down in the spectrum to be able to help us.
Exactly. Thank you.
At least one of the problems we have in patient-driven requests for some of the technology that's out in the public before it's validated scientifically. We have, I'd say at least once a week, someone asks for cDNA, and it takes about 45 minutes to discuss why do we maybe not want it, and what are we going to do with the results.
Well, I share your pain. And actually, I would say that the even worse pain, as somebody who often sees patients who, you know, in my part of the country, there are a lot of naturopaths. One of the naturopaths in our area is ordering garden assays.
Oh.
So I'm getting this test result whether I want it or not. And I know you'll be shocked to know that sometimes they show up positive, whatever that means. So that's an even longer discussion, which is why, you know, I think that the mutation that they think they found in this is probably CHIP, right? It's probably not suggestive of recurrence of your breast cancer. So I don't have an answer for you on that. It's really tough, and I think you can only point to guidelines. And I haven't looked at NCCN recently, but I don't think in the breast space it's recommending it as a matter of routine. So I usually try to remind people about, you know, don't know what's going to change your outcome. I don't know what to do with the information. And I've just told you about my patient with a garden who has this hype where she's terrified she has metastatic breast cancer. And she probably has CHIP, and that's not something I'm excited about talking about either. So it's quite complicated. You know, you've done this so many times in oncology. I think lots of times our technology outstrips our ability to use it in a evidence-guided fashion. It's tough to talk about with patients.
It's the same speech I have every week.
I'll yield to that microphone because I've asked one. You go first.
Based on the early results of Destiny 6, have you started using ADCs in the frontline setting for metastatic disease in lieu of standard chemotherapy, or are you still waiting for you know, the FDA to clear that?
I'm a real conservative practitioner, so I am waiting for the FDA approval. That's just me personally, and I think our practice generally is. We're waiting for that label change. But, you know, these are very interesting data. What are you doing?
I started using it because, I mean, the data's there. I wouldn't, a lot of times I've seen the data be delayed by the FDA for many months with patients that could really benefit from this treatment. So I think I had my first, you know, not like 10 patients, but
Right.
a couple of patients where, you know, they're really concerned about toxicities, already had an anthracycline or
Have you gotten it approved through insurance?
The few patients so far, yeah.
So I'm interested in a show of hands on that one. Can I? How many have been with our colleague that you have found reason to, and the opportunity, I guess, and the ability to prescribe a first-line ADC like that? Hands up. It sounds to me like if others want to pursue that, they should talk to you about how you made that happen. Or maybe to your prior auth people.
So this is not a question, this was a comment based on what was just discussed. When I'm in that situation, I tell patients that we did these studies long ago when we didn't have any of these techniques or technologies available to us on looking for cytokeratin positive cells in the bone marrow of breast cancer patients. And patients who had those cells positive, not all of them relapsed and died. So body can live in symbiosis with a little bit of cancer immune system keeping it suppressed. So that's how I answered that question. Say these tests are too sensitive. We don't know what this means. And I also don't order these tests because I feel that if you find somebody tied to the train tracks, the best gift is not a pair of binoculars. So I don't want my patients to find out early on that they are going to relapse. If I have no intervention proven that that will prolong their survival or cure them by early intervention compared to a little later intervention. So I'm waiting for those data. I'm conservative like you.
Yeah, I think actually the place where I think it's the most provocative right now, and again, I'm curious about whether you're doing it or not, is the PADA trial in metastatic breast cancer. Everybody remember that trial? So this is a trial where they were looking at circulating ESR1 mutations, right? So we're looking specifically for estrogen receptor mutations in people who are on metastatic hormone therapy. And they're following them, and if the patient has an elevation in her ESR1 suggesting resistance is developing, they randomly assigned her to either continue the same therapy, so long as her staging was negative, or to switch over to a SERD. And the people who took the SERDs did better. So I think this is, provocative. And it's the one trial I'm aware of where not only did they do testing, albeit for a very specific gene, but they had an intervention, and they could see what happened if you made the intervention or did not make the intervention. Now, I'm still not following that yet. There's some other trials that are trying to replicate that, the Serena trial amongst them. But I think that, this may be coming. But having both the measurement and the solution, some kind of intervention which is evidence-based is really important to me, and it sounds like to a lot of you.
Dr. Davidson, it's hard to give a breast cancer update and not talk about our dilemma of ultra low and low HER2. So a comment, how does your institution, how does your pathologist, who I think left the room, good for him.
I was just going to say, I told Liren if this question came up, I was going to send it to him. And it looks like he took that as an opportunity to go to the airport. They're struggling. Are there any pathologists in the room? If there are, they're not speaking, huh? Our pathologists are struggling as yours are. I'm waiting to see whether or not our fields will come together as we have in the past with some, updated guidelines. It's hard to know. I always worry for our pathologists. I feel like there's a pretty heavy burden on them. They know if they call it negative, I'm not going to go there, right? Whereas if they call it positive, then I might be going there. And so it's tough right now. I don't have an easy solution for that. And I think I'm fortunate that I work with only one set of pathologists. I can imagine that some of you who may have a more diverse practice, you may have several groups that you're working with, and that probably makes it even tougher.
I think I have one last question. So you showed us a wonderful slide about ctDNA. What's your approach on Keynote 522 in the post-neoadjuvant setting in patients who did not achieve a pathologic complete response, and to look at ctDNA levels in those patients and maybe escalate, de-escalate post-neoadjuvant IO?
I haven't been looking. The same thing. I don't think there's any evidence to help me one way or the other. If somebody's had a path CR, she's having a lot of toxicity, and that I'm sure that all of us have a lower threshold for thinking about discontinuation of therapy. Is that true? Yeah. But I haven't been using any biomarkers to try to help me here. It's been more a clinical judgment with the knowledge of their pathologic status.
Yeah, and we do have a trial
Yep.
ongoing for that. We actually have that trial.
All right, well, thank you very much.
Thank you, everyone.